Welcome to Passive Curiosity in an AI world where we explore tomorrow's careers through the lens of AI. The choices we make for kids today echo for a lifetime. Dr. Natalie Pageler uses AI to help doctors notice the moments that could change a child's life, for better or worse. Let's get curious. Today we're continuing our AI in Healthcare mini-series with a guest who works at the intersection of pediatrics, technology, and systems-level thinking. Dr. Natalie Pageler is a board-certified pediatrician, pediatric intensivist, and clinical informaticist at Stanford Medicine. She serves as the inaugural division chief of clinical informatics, a clinical professor of pediatrics, and the associate dean for maternal and child health. Her work focuses on designing safe, ethical, and meaningful uses of AI for children and families. A challenge that looks very different when your patients are growing, changing, and often unable to speak for themselves. Before stepping into her current leadership roles, Dr. Pageler spent more than a decade transforming how Stanford Medicine Children's Health uses digital systems, earning national recognition for improving care delivery. She also helped launch one of the country's earliest clinical informatics training programs, helping define a career path that didn't really exist a generation ago. Dr. Natalie, thank you so much for joining us.
My pleasure.
To start off, if your teenage self could follow you around for a week, what would they see you doing and what might surprise them the most about your job today?
Yeah, thank you so much. It's a great question. And I definitely did not foresee myself having this role when I was a teenager. And my role has changed quite a bit. I've been very lucky. So I had considered going into medicine even as a teenager, but didn't realize how many different opportunities there were within medicine. I envisioned it as being purely the clinical practice. And so I think I would be surprised to see how much of my time has been more about shaping systems, about helping to influence how healthcare is practiced, and that a lot of my time is spent in meetings and conversations in addition to my clinical practice.
Interesting. Especially that shift from one patient at a time to reshaping the whole system. What was the moment that helped you make that leap?
Another really great question. I love being a clinician, and I am, as you said, I'm a pediatrician. I've worked in pediatric critical care for many years and am also now working in pediatric primary care, so different kind of ends of the spectrum of pediatrics. And in both worlds, what you see is that a lot of what you can do with an individual patient and family is influenced by the system that we're working in. So back when I was doing my training in pediatric intensive care, pediatric critical care, we were also simultaneously rolling out our electronic health record and new technologies. And I could see how much that technology was shaping my ability to provide safe pediatric care. And so our chief medical information officer at the time, Dr. Longhurst, was talking with me about the potential to improve how we ordered our laboratory tests in the pediatric ICU. And so that got me into a project to try to improve general ordering, which got me really interested in the idea that in direct pediatric care, I can affect one patient and family at a time. But if I try to make it easier for clinicians to practice, I can affect multiple patients and families at a time. And I really found that I love that balance between doing direct patient care and really having that meaningful engagement with children and families, and then going to the bigger system level and trying to improve how all pediatricians could provide care.
How do you decide which problems are worth solving at a system level rather than one patient at a time?
It is challenging, and I think part of what we look for are general trends. So, again, in my career, I love pediatric care, and it's very important for me to continue that piece. In my practice, I will notice that sometimes I run into the same issues over and over and over. And that's where you begin to realize that if I address that issue, it decreases the burden for me to focus on the individual child and family and address their specific medical issues. I am one perspective, but having that experience helped me understand that we really need to gain the perspectives of all of our caregivers, our pediatricians, our nurses, our respiratory therapists across the health system to understand which issues are coming up over and over. And some of that we can do by talking with them, by rounding, by having advisory groups. And some of that we can do by looking at the data critically and saying, hey, we're hearing or seeing this particular issue. Can we look into the system and see how often this is happening? And sometimes something that seems like it's common when you look at the data may not be, and vice versa. And so really trying to get both that understanding from our clinicians, where are the real pain points, where are the potential danger zones, and also looking at the data to understand where is there truly high value intervention, and then prioritizing accordingly.
I love that balance between both listening to clinicians but also checking the data. Now, kids are obviously very different from adults. They're growing and can't always speak up for themselves. How does that change the way you design AI in pediatric care?
It is challenging to think about how AI should play a role in children's care, and there are many differences between children and adults, as most people know. And so when I'm thinking about how do we deploy AI in pediatric care, there's kind of four different categories of issues that I think about. So first is just that their children and their families may have different needs than our adult patients, and so as we're thinking about which issues to tackle in pediatrics, we need to make sure that we have the right stakeholders at the table. So we need to have pediatric care providers, we need to have pediatric patients and their families. Again, in pediatric care, we are always thinking about the child and the family. And we need to make sure that we've got a whole range of health system leaders that specifically focus on kids to help us shape the right questions and make sure that we are prioritizing appropriately. So that's category one, is getting the right people at the table to prioritize what we're going to tackle. Category two is thinking about, do we have the right data? So for many reasons, we tend to have less data available for kids. In general, kids are healthier than adults, thankfully. When you're looking at any one pediatric medical condition, you may have a lot less data around that. Children make up about 25% of our population, depending on exactly what age groups you look at. But, again, they're alone. It's a smaller portion of our population than what we have in the adult space. And then also children are very different across the age spectrum. So a baby is very different from a teenager. And so when you start thinking about how can I get data around each one of those age groups, the data becomes even smaller. And you add on some of the ethical considerations about wanting to make sure that we are getting pediatric data and protecting it appropriately. And so sometimes there are some extra barriers to getting that data, or perceived extra barriers that make some people just say, I'm just going to cut out kids altogether. So for all those reasons, we would need to be really thoughtful about how we get enough pediatric data to feed the AI models. And then we need to think about testing those models in pediatrics and across a different age spectrum. So again, a lot of models are created for adults. So classic example, the Apple Watch. It can detect abnormal heart rates and heart rhythms in the people that are wearing it, but it wasn't designed or tested on children initially. And so we have had teen patients walk into clinic and say, hey, look, I've got this arrhythmia alert on my Apple Watch. And we're realizing maybe there is some value for teens, even though it wasn't tested there. So we need to do that testing of models specifically in the pediatric age groups and in different pediatric age groups, because something may work for a teenager but wouldn't work for an infant. And then finally thinking about the interventions that we do with that. And again, often in pediatrics, we're thinking about children and families. So really deciding, are we choosing the right intervention, and are we understanding both the positive and negative impact on both the child and the family?
That's a really helpful way of framing the impact of AI. In pediatrics, the cost of mistakes can echo for decades. How does that long term horizon affect how cautious or ambitious you are with AI?
Yeah, and that's such an important point. And even though children are a smaller part of our population, the point that you're getting to is interventions that we make in childhood can last a lifetime. And so that can be, you have to think about it cautiously because it could potentially negatively affect a lifetime. But also, it's a huge opportunity. So if we make interventions in childhood, that could lead to years of healthier and more productive lives. And so I really advocate, and a lot of my colleagues really advocate for more thought, more interventions, more preventative care going into that pediatric space so that we can really help shape health and happiness and productivity for a lifetime. So I think that's what we want to look at. We know that there are certain behaviors, there are certain interventions that we can do in early childhood that will help shape healthier practices. And so trying to focus on those where we know what the right thing to do is, and can we use some of those AI interventions to help support that path. So yes, we need to think about it. Yes, we need to understand that it affects the lifetime. And I think that's where the opportunity is.
We've talked about children as the patients, but for the students who may often imagine AI as something that appears overnight, what kind of invisible work determines whether an AI tool will succeed?
Great question. And, I think we're thinking and talking a lot about AI, and especially this kind of latest version of AI, because it is very exciting. And I think it's important to recognize, and I know you know this, that AI in different forms has existed for many decades now. And we're really now into this age of generative AI, which is incredibly exciting. But a lot of the considerations that we think about in AI are the same considerations we think about in technology in general. And so the way that I often think about putting technology into the health system is based on my training in clinical informatics. So, in clinical informatics, for those of you who haven't heard that term, the way I define it is the implementation, evaluation, and optimization of our health information systems within healthcare to improve quality of care, patient safety, patient and family and provider experience, and ultimately outcomes. What we're often thinking about as we're trying to optimize our health information systems is not only the technology, and in fact, oftentimes the technology can be the smallest piece. What we're thinking about more often is people, process, and technology. And so, really thinking about how can I take a technology, a new technology, and in this case, generative AI, so exciting. How can I take that and train the people that need to use it appropriately and put it into the process, into the workflow in the right place so that it can enhance what we are doing? So when we're thinking about it, yes, it seems there's lots of technology, it's super exciting, but we are being really thoughtful about how and where we use it and how we test it. So even though it seems like it's coming in kind of overnight, what you're seeing in clinical practice is the result of many years of both developing it, thinking about the workflows, and then doing tests, doing trials in clinical practice to understand which technology is helpful and what some of the unintended negative consequences might be so that we can safely, meaningfully, effectively, and ethically put it into practice.
Keeping that in mind, can you share an example of where a digital or AI driven system didn't work as expected, and what that might have taught you about designing technology for healthcare?
Yeah, unfortunately, there are way too many examples of that. And again, that's why it's so important to be thoughtful about how you put it in and study it and then take it back out if it's not working. So, kind of stepping away from the AI into kind of a little bit more mundane interventions, as the electronic health record was being put in, we suddenly had a lot more opportunity to document and capture information, which is helpful because it helps us track things. It does help us study. But what we often found is that in order to get that information in, it required people to enter information, to become kind of data clerks. And so there have been several examples over the years where we've tried an intervention to help theoretically improve patient safety. Like, we'll have people document this extra step to make sure they're all doing it. But then when you add all that documentation, that sometimes means that nurse or that physician is stepping away from the bedside and spending their time entering into the computer. And so we've had examples where we added a documentation step to improve patient safety because there was some concern. And then later on down the line, the same thing happened over again. And we realized that adding that documentation step didn't happen at the right time. So back to that process question, right? It happened afterwards. So it didn't help them to make the right decision and do it in the right time. And so thinking about both, how can we make sure, again, that we put that intervention into the right place in the workflow so that the person is getting the information, getting the reminder at the right time. And then also, how can we automate some of that documentation? So whether it's through computer vision, whether it's through integrating another system so we're automatically getting the information instead of somebody having to type the information. The more we can automate that, the more accurate it is and the less it takes away from the clinician's time at the bedside. So that's been kind of a common theme throughout, and there's been several interventions that we've redesigned to, again, put them in the right place in the workflow so you get the right response. And then also thinking about how can we automate capturing some of this data so that we're not putting so much documentation burden on people.
Honestly, that theme of reducing burden keeps coming up a lot over my conversations.
Absolutely.
Given the real consequences you face in healthcare, when you train clinicians or trainees, how do you teach judgment around AI, rather than just how to use a specific tool?
Yes, and a super important point. And I think the tools are evolving so quickly that it's important not only do we teach people about the newest tools, but teach people how to constantly learn. And that's going to be a theme. It has been a theme for a long time, and now it's becoming even more important because everything is changing so quickly. So I think, again, teaching people about some of the fundamental principles around technology and how people interact with technology can be really helpful. So, for example, one of the kind of concepts that I often like to talk about is this concept of automation bias or complacency, and automation neglect is a kind of a new term. And this goes, again, back a long time to other more basic forms of technology, but that as we are introducing new technologies and getting used to them, different people may change the way they think about their former processes. And they may say, oh, the machine's telling me to do this, the computer's telling me to do this, it may be right. So even though I would have done something else, the computer must be right. Conversely, sometimes with our more experienced physicians, especially with this age of AI, we're seeing this concept of automation neglect, where somebody's like, oh, I know how to do this, the computer must be wrong, and I'm going to ignore what it's saying inappropriately. And so even teaching these principles about how humans naturally interact with automation and technology can be really important in helping them evaluate going forward. Oh, where might the pitfalls be? How do I make sure that I am appropriately monitoring? And how do I make sure that I am thinking about some of my own internal biases and whether or not I accept this advice from the computer? Similarly, again, continuing to teach people how these technologies work can help them understand where their limitations may be. This is changing rapidly, right? So again, if you think about generative AI right now, we know there are things like bias being integrated into large language models. It's important that people understand that and understand where that bias may seep in. We know about hallucinations and that the systems sometimes make up facts. And again, that's based on the technology that underlies those systems. But people need to be very aware of that and recognize that they are responsible for checking every piece of data. So that's how we think about the large language models. But again, each technology is going to have new limitations, new advantages. And so we need to train people. How and where do you go to learn about each new technology? And how do you learn about what the limitations are and what you need to be watching for and bringing to the table? So a lot of it is about teaching people to learn and to teach themselves as the technologies evolve.
You gave a great example of ethical tension. Could you give a specific example of where one of these ethical issues appeared in day-to-day decisions?
Yeah, there's a lot of examples. One of the examples I like to cite, because I think it's kind of so clear as we're thinking about AI, is the examples of using AI to predict who may not show up at clinic. So one of the common examples we think about is using a predictive model, an AI model, to decide who may be at risk for not showing up to their clinic visit. And so I talked about, kind of all of the different considerations in pediatrics, and you'd want to make sure that you have a model that's specific for children and families and some of the concerns that might create barriers to them arriving in clinic. But as a health system, when you've got this model, there's a couple different ways that you could use this model. So in some health systems, initially when these models were created, they said, okay, I know that some people aren't going to show to their clinic visit, and I want to make sure that I'm being efficient in clinic. So I'm going to overbook my clinic. I'm going to book more people than I would actually think could fit, because I know there's a high likelihood that a certain portion of people aren't going to show, and I want to make sure that we're using all that time efficiently. The challenge with that is then if a person who had a challenge getting to their clinic did actually make it, they're getting to an overpacked clinic. So you can imagine in pediatrics, where you might have a mom or dad who is very busy and has multiple children and has challenges with transportation or challenges getting childcare to bring their sick child to the clinic. If they show up to the clinic and it's over busy and overpacked and the waiting room is, filled to the rim, that makes their experience worse and decreases how much time they can get for their health care. So instead, at Stanford Children's and at a few other organizations that I know of, what we're doing is we are looking at those algorithms and thinking, okay, why are they not likely to show? And then calling those patients and families and asking them, are there barriers that we can help you overcome? Can we change your visit to a telehealth visit? Is there a way that we can help with transportation? So that's one of the very subtle kind of ethical questions. When we have AI, how do we use it? What intervention do we pair it with? And depending on what intervention we use, we can have an intervention that makes things worse for a family, or that helps improve health equity and makes things more fair and gets some of our families with the highest burdens, gets them better care.
That's such a powerful example of how AI tools can either worsen inequality or help reduce it, depending on the way we shape them. As someone shaping training programs, what skills do you think future pediatricians will need that weren't emphasized when you were a student?
I think some of this has been in existence, but it's just becoming more important. And so again, kind of re-emphasizing the points I was making a little bit earlier, everything is changing so quickly. Technology is changing so quickly. So more than ever before, we need people to be lifelong learners. And we talked about that, like I said, for a while. It used to be kind of in the medical knowledge realm. We knew medicine was advancing. We knew medical care was going to change. And so we talked about training physicians to be lifelong learners so that as medical advances came into existence, we were learning about those, knowing that we needed to keep studying, knowing that we needed to keep reading the journal articles to understand the latest advances. Now it's not just about the healthcare advances, but the technology that's shaping our systems and that we need to integrate into our practices in order to provide the best care. So I think it is really important so that some of these fundamental concepts of clinical informatics, are trained to all of our medical students, all of our residents and fellows, so that they understand where, again, the potential is, where the limitations are, how to optimize the use of these technologies so that they can provide the best care, and how they can continue to learn and stay on top of the newest technologies so that they're incorporating them safely into their practice.
So you're saying the key is adaptability.
Absolutely, absolutely, which is challenging but so important, and I think can be really exciting and engaging.
Similarly, clinical informatics wasn't even a recognized field a generation ago. How should students think about building careers around topics that don't have clear job titles yet?
Right. Yeah. So clinical informatics as a physician subspecialty didn't come into existence. The first board exams for it were offered in 2013, and the first class of physicians who were certified, board certified in clinical informatics was in 2014. So you're right. It is a very new field and nothing that I had ever heard of when I was thinking about medicine. And that will continue to happen. We're going to continue to have new technologies and new ways to practice. I think, again, harping on that point of the most important thing is to know that you're going to have to continue to learn throughout your practice and throughout your lifetime, and preparing to become that lifelong learner, and then being open-minded. I had an engineering background in undergraduate, so I had a little bit of a technology background, but didn't know what clinical informatics was because it didn't exist. And when I was going through my training, my residency and my fellowship, started to see some of these exciting questions and started to see, this new technology, the electronic health records at the time, and got excited, got interested, and like I said, ended up working with Dr. Longhurst, doing a study in it, both learning the results of my particular study, but also learning about the broader field, and then got to help shape the field because we were some of the earliest people practicing it. And so I think that's the trick, is be open-minded, know that you're going to be learning, jump in, get curious, and then think about, as you're getting excited about something, how can you help shape the next generation? How can you help shape the field? It's one way to have a really great and rewarding career.
So, looking ahead, if we get AI right in pediatric healthcare, what do you hope changes for today's kids when they're patients decades from now?
Yeah, I think the potential is huge here. We, again, as we've talked about, we know that interventions that we do in childhood can affect a lifetime and can affect our entire world, right? Everybody starts off as a child, so it gives you an opportunity to intervene in everybody's life. And I think what we are hoping is that as we capture the power of AI, that we can become more precise in our care. We can understand the individual child and what they specifically need to be healthy, happy, and productive throughout their life. And we can switch from this kind of intermittent reactive care, where we're only jumping in and doing something when something's gone wrong, to a continuous, supportive, proactive approach. We can predict, hey, if we do this now, this will prevent you from having problems. So that's the real potential that we see with AI in pediatrics. And I'm excited there are so many people working on this to make that a reality.
What a beautiful vision, and I can't wait to see how it plays out.
Me too.
One last question. For students who care deeply about kids, systems, and impact, but worry they may need to choose just one, what would you want them to hear?
Want them to hear that there is so much opportunity, and I think there is so much potential at the intersection of different fields. So love that there are people that are interested in pediatrics and technology and computer science and systems. The more we can bring together the knowledge from those different fields and really think about the opportunity at that intersection, the better off that we will be. I've had a background in engineering, went to medical school, didn't think that those two aligned, and have found so many places where my knowledge in different fields has really helped me to see a clear path forward. So bring it on. There's so much opportunity.
Well, Dr. Natalie, thank you so much for sharing your perspective on AI, education, systems, and what safe care looks like for kids.
Thank you for having me. I love this podcast, and it's been my pleasure to talk with you.
Thank you again. And for our students listening, remember, the goal isn't to predict that one perfect job. It's to build judgment, adaptability, and curiosity, skills that grow as AI and healthcare continue to evolve. If today's conversation sparked your interest, explore our other episodes in our AI and Healthcare mini-series. And to help you visualize how these roles are changing, check out our AI and Healthcare Future Jobs Map and resources linked in the show notes. This has been Paths of Curiosity in an AI World, where we explore tomorrow's careers through the lens of AI. Until then, stay curious!